Thank you for the introduction, and I'm delighted to be on this panel with such amazing advocates. In this presentation, I'll be touching on four key areas. First, why stigma and discrimination is important for U equals U. Second, compounded stigma and discrimination through a gender and age-related lens. Thirdly, Global Fund guidance and investments in related areas. And lastly, I'll share an example of what I think is good practice from our work. On this slide, you'll see some work that was commissioned by UNAIDS. It shows that violence is associated with higher rates of HIV infection amongst women. And it also shows that stigma and discrimination impact negatively on HIV testing, on linkage to care, on ART adherence, and on viral suppression. It also highlights the importance of addressing structural barriers, such as access to education. And you'll see here that with a reduced risk of HIV infection for each additional year in schooling. As I mentioned on the previous slide, there's plenty of evidence that stigma and discrimination and other human rights barriers to services interfere across the cascade with negative effects on the effectiveness of prevention, testing coverage, and adherence to treatment. And you'll see here in these examples how stigma and discrimination impact on the overall quality of life of people living with HIV in key populations. Fears over a lack of confidentiality was shown to undermine testing uptake across sub-Saharan Africa. The fear of stigma prevented trans women from testing for HIV in New York City. People living with HIV experiencing stigma were more likely to present late for HIV care. Studies in a number of African contexts have shown that stigma is a barrier to effective prevention of vertical transmission. And fear of disclosing to partners is shown to be a barrier to treatment initiation. Many groups reported stigma as a deterrent to ART, and stigma has been shown to undermine treatment adherence. I think many of you will hopefully be familiar with the People with HIV Stigma Index, designed and led by GMP+, the global network of people living with HIV and other key population networks, and in collaboration with partners such as UNAIDS and PEPFAR. Here are just some examples of different types of stigma and discrimination experienced due to HIV status. And it's broken down to show the different experiences of key populations and non-key populations. For each of these areas, exclusion from family activities, discriminatory remarks from family members, verbal harassment, blackmail, and physical harassment, the evidence shows that key populations living with HIV are more likely to experience stigma and discrimination than their counterparts. That is, people with HIV not identifying as key populations. In addition, stigma and discrimination, criminalization of key populations, and abusive law enforcement are associated with breakdowns in prevention services and higher HIV and STI infections. So key populations living with HIV, including women from key populations living with HIV, are being left even more behind throughout the cascade. It's also important to recognize and for us to be addressing the interplay between gender inequities and stigma, as they also lead to compounded stigma and discrimination. And I'll just give one example, which is an example of women who use drugs. Typically, in many contexts and cultures, or probably most contexts and cultures actually, women who use drugs, especially mothers, are viewed with more judgment than their male counterparts, leading to more stigma and discrimination and often harsher prison sentences and legal judgments. When women who use drugs are also living with HIV, then this reality is further exacerbated, for instance, in healthcare settings, communities, and criminal justice systems. Age is another factor that adds additional layers of vulnerability. Gender norms, unfavorable power relations, including due to age-disparate relationships, Stigma associated with sexuality and violence are all associated with higher vulnerability of adolescent girls and young women. Poverty and being out of school are other aspects that can hinder effective HIV prevention amongst this group and can lead to higher incidence rates. Often in families and communities and educational settings, these are not supportive of young women being sexual beings, nor do they equip them with the tools and life skills required to navigate healthy sexual relationships that include condom use and other HIV prevention tools. For adolescent girls and young women already diagnosed with HIV, services are rarely youth-friendly and often judgmental, which in many cases leads to low uptake of services, low retention, and low treatment adherence. Adolescent young girls and young women from key populations face further layers of stigma and discrimination and judgment, which impede their ability to seek out, take or demand action to address their needs. And lastly, young women born with HIV may face a multitude of challenges for their health and well-being. Many are not even informed of their HIV status until they're quite old, which further impedes their ability to stay safe, adhere to treatment, and to embark on happy and healthy sexual lives and relationships that are free from stigma and discrimination. So I was one of those rather naive people who a few years ago believed that wider access to effective antiretroviral treatment, resulting in undetectable viral load and subsequently no risk to our negative partners, would mean an end to much of the stigma and discrimination that has been faced by HIV since the beginning of the epidemic. Sadly, that's not really happened, and sadly, stigma and discrimination is still thriving in our communities despite all the work that's taken place to date. So what are some of the issues at play here? I've already spoken about how compounded stigma and discrimination interferes with women achieving U=U. Stigma and discrimination and other human rights related barriers continue to pose challenges for reaching women and girls with the appropriate services and messaging and support more than 30 years into the epidemic. And they interfere with women's uptake of testing, timely enrollment, or treatment adherence. Another challenge is that many women are yet to be fully engaged. In a study in 2018, it was revealed that 40% of women living with HIV had not been informed about U=U by their medical practitioners. WHO HIV testing service guidelines, which were launched in November 2019, state that at the time of diagnosis, providers should educate that people with HIV on antiretroviral treatment who achieve and maintain viral suppression cannot transmit HIV to their partners. Clearly, this is not happening. And it's clear that efforts to reduce human rights and gender-related barriers need to continue alongside U=U messaging. Unfortunately, U=U does not mean an end to criminalization, either overly broad HIV criminalization, as well as criminalization of key populations. And as I mentioned before, U=U does not result in an immediate end to stigma and discrimination. Women with HIV continue to be judged for having children, for multiple partners, for using drugs, for engaging in sex work, for their trans identities, sometimes for just being themselves. Programs are still desperately needed for comprehensive responses to stigma and discrimination in communities and healthcare settings, as well as to address internalized stigma. As one of the largest funders of HIV programs worldwide, the Global Fund is making significant efforts to address gender and human rights related barriers to access. And this includes making sure we're funding gender transformative programs and programs to reduce human rights related barriers, including gender related stigma and discrimination. We promote gender responsive programming in the design and implementation and monitoring and evaluation of our grants, and support gender transformative programs where it's possible. We invest in programs to reduce human rights related barriers, including programs to reduce stigma and discrimination and gender related discrimination experienced by women and girls in all their diversity. And we've recently developed and disseminated guidance on removing human rights related barriers into services in the time of COVID-19, which highlights that gender related aspects of existing barriers may further be exacerbated and or that new gender-related barriers may arise in the context of COVID-19. We have a specific focus on scaling up programs to support women and girls, including advancing sexual and reproductive health and rights, and investing to reduce gender and age-related disparities. This initiative is focused on adolescent girls and young women in 13 priority countries, where HIV burden amongst this group is the highest. And I'll just highlight a couple of points here. Firstly, stigma reduction is part of the package that we're providing in 8 out of the 13 countries. And secondly, Her Voice Fund, which has provided community-based organisations with small grants reaching over 7,000 adolescent girls and young women. And this is important, and I'm highlighting it because we consider the meaningful engagement of young women in all their diversity to be a prerequisite of effective women and girls-centred programmes. Her Voice also supported thousands of young women to take part in the recent Global Fund strategy development consultations. Another key area linked to this is our commitment to introduce and scale up programs that remove human rights barriers to accessing HIV as well as TB and malaria services. And this is linked to both our founding principles at the Global Fund and the strategic objectives embedded in both our current and our previous strategy. Between our last and current funding cycles, we've seen an increase in over 40% in funding for such programs, and this is an increase of around $40 million. We recognise that technical fixes are not enough, and that mere availability of services does not necessarily make them accessible, acceptable, or of good quality. And programmes to reduce human rights related barriers include programmes to address stigma and discrimination. They're not nice to haves, they're absolute non-negotiables. Therefore, our Breaking Down Barriers initiative provides intensive support in 20 countries with the aim to build multi-stakeholder buy-in and ownership of comprehensive national responses to address such barriers. And I just want to stress the multi-stakeholder nature of this work, which takes place with communities deeply involved alongside government ministries of health, of justice, of gender, other country stakeholders, and technical and UN partners. And there's a big emphasis on documenting the lessons learned from this process and measuring the impact and results of this work, which I'll talk about a bit more on the next slide. This slide just gives a taste of some of the early evidence of impact that we're getting from the midterm assessments of this initiative. And I've highlighted just 3 findings in red here. The greatest progress that we're seeing is in programs focused on stigma and discrimination reduction for HIV, as well as for legal literacy and services for TB. The midterm assessments identify key elements of success, and these include commitment and engagement of stakeholders across sectors over time, integration of efforts across diseases and into basic programs, and importantly, community participation and empowerment, as well as long-term implementation support. I also wanted to highlight that progress we've seen is possible even in quite restrictive contexts. And I just wanted to highlight this because it's somewhat encouraging that despite some of the very negative direction we're seeing on human rights in some part of the world, progress is still possible. Now, this is a very dense slide, so I hope you can read it, but there's so much rich information and reason for hope in this one example that I'm sharing from Botswana. So first, starting with the problem, in Botswana in 2016, 67% of women, which is roughly double the global average, reported having experienced gender-based violence, and less than a quarter of them reported it to the police. COVID-19 lockdown has further exacerbated the situation. In 2017, law enforcement were major perpetrators of violence against sex workers, with 40% of sex workers having had experienced physical violence and 40% ridiculed or refused assistance. Through our BDB baseline assessment in 2018, this informed human rights and adolescent and girls and young women interventions in Global Fund grants that are currently under implementation. And the subsequent National Comprehensive Response Plan focuses on addressing gender-based violence, including through sensitization of law enforcement. Programs that were funded included Stigma and Discrimination community dialogues with traditional leaders. The government of Botswana developed gender-based violence protocols and standards in healthcare and integrated GBV content in pre-service and in-service training for the Botswana Police Service. In-service sensitization activities with police were undertaken by several of the key population-led organizations in Botswana. Women Against Rape and the Botswana GBV Prevention and Support Centre, providing counselling, referrals and HIV and STI testing, PEP and emergency shelter. They also sensitise police and provide outreach programmes targeting youth and students. Benella, a human rights organisation, has done podcasts on COVID-19 and GBV and police brutality. They also challenged a campaign that encouraged consumption of alcohol at home. And UNDP training for traditional leaders with knowledge and skills to tackle gender-based violence has also taken place. And lastly, and importantly, what change are we seeing? Well, I've talked about some in the programs, but also in September 2020, the land policy was amended to give married women in Botswana the right to own land, conferring greater economic independence within marriage. And the police are now more willing to engage with key population-led organisations, and the latter refer clients to police stations where sensitization training has occurred, designated as a key population-friendly space. So I just wanted to end with a few thoughts on some of the things that need to happen to reduce stigma and discrimination amongst women living with HIV or vulnerable to HIV, and to ensure that U equals U becomes a reality for all of us living with HIV. So, firstly, comprehensive programs to address human rights and gender-related barriers must be part and parcel of making U equals U a reality. And they must be part and parcel of broader efforts to achieve epidemic control. We also need to make advocacy for accountability and advocacy for changing of harmful gender norms everyone's responsibility. The burden should not just lie on women's shoulders. Meaningful engagement is also key, informing women, empowering women, ensuring autonomy and agency. And leadership of women living with HIV in all their diversity is another essential element, beyond just lip service, because sadly we often hear this being spoken about without the principle actually being put into practice. We need leadership at all levels in planning and implementation and oversight of HIV responses, including but not limited to women and girl-friendly and community-led HIV services and responses. And I might point out that this is something I've been saying for over 30 years. I feel like I truly am a broken record. But despite the progress that has been made, and there has been progress made, the change that we've seen is not at the level of change that we need to see. Another area where I think we need progress is having donors and technical partners work alongside communities to support comprehensive responses and coordinated provision of technical assistance and capacity development for stigma and discrimination reduction and other efforts to address gender and human rights related to barriers to access. And this includes, I think importantly, the scaling up of peer-to-peer technical assistance models, which is something that we have been trying to support at the Global Fund. And last, but certainly not least, adequate funding for all these efforts is going to continue to be a critical challenge and something that we really need to be doing better on and getting right. And with that, I will end and thank you.